Good morning, everyone, and welcome to the IS webinar on targeted advice for families with children. My name's Trevor Moffat, and I'm joined here by
Megan Brown.
And we're hosting today's webinar. We'll quickly run through the technical details for the webinar, then we'll pass over to our panelists. What we'll have today is we're going to run through about 30 to 35 minutes worth of presentations. Then you will have the opportunity to send in questions for our four panelists. To do this, if you look to the right-hand side of your screen, you'll see a small dashboard with some options. One of these is a question box. If you just type in there, myself and Megan will pick up all your questions throughout the presentations. You can write them at any point, and we will pass them on and ask them on your behalf. Sound has been disabled for all our delegates. I will just pass over to our first panellist, Hannah McCulloch.
Thanks very much, Trevor. Good morning, everyone. Thanks very much for joining us today, especially those of you who were deleted and had to re-register. Extra points for perseverance there. So as Trevor said, my name is Hannah McCulloch and I'm the National Coordinator for Local Child Poverty Action Reports with the Improvement Service. And I organised today's webinar along with Karen Carrick, who's the Evaluation Manager for the Improvement Service. For those of you who don't know, the Improvement Service is the national improvement organisation for local government in Scotland, and we support local government through providing advisory services, including consultation and facilitation, skill development and research, and a whole host of other things. So with me today, along with Karen, we have Sylvia Bakey from NHS Lothian, and Sylvia will be talking about the Maximise programme in Edinburgh. And after Sylvia, we'll have Leslie Nish from NHS Greater Glasgow and Clyde, who will be talking about the Royal Hospital for Children Money Advice Service. And Karen will say a few words at the end. So before we move on to the interesting practice-based part of the webinar, I just want to give a bit of background from a child poverty perspective. As I said, my role is National Coordinator for the Local Child Poverty Action Reports, and the reason for my post's existence, and a big part of the reason we're here today, is the Child Poverty Scotland Act. And the Act was passed by the Scottish Parliament back in 2017, and it sets ambitious targets for the Scottish Government to reduce the number of children living in poverty by 2030. As well as placing that duty on the Scottish Government, the Act also places a duty on local authorities and health boards to jointly produce annual child poverty action reports highlighting the steps that they are taking to contribute towards those national targets. So before we get on to the very practical focus of today's webinar, I just want to say a few things at a sort of strategic level. Firstly, I think it's worth reminding you, although I'm sure you don't need reminding, that efforts to tackle child poverty locally are set against an extremely challenging backdrop. Rates of child poverty are projected to rise rather than fall if there aren't major policy levers pulled, and also the powers available at local level are relatively limited. So if we're serious about making a difference, and I've no doubt everyone listening is very serious about that, we need to continue to push to ensure that there's a concerted, joined up effort across all departments and all disciplines. So tackling child poverty will be about housing and childcare and employability and transport and access to employment and skills for parents and all those other levers at local disposal. And we need our focus to stay on long-term preventative measures that will help lift parents out of poverty over years, not just mitigate the impact of poverty and reduce the suffering that can often come along with poverty, although that's obviously really important too. I think we need to get the balance right. So with all that in mind, it's clear that information and advice is only part of the solution, but it's an extremely important part of the solution, because if we get the right advice at the right time to families, we'll not only help them to avoid crisis, but also help to put them on a more stable footing in the longer term, and perhaps channel them into wider sources of support that will help them find work if they need to access affordable housing and that kind of thing. So finally, before I promise I will hand over to Sylvia, I just want to mention that the two examples we're showcasing today, I know, are not the only examples of excellent targeted advice going on across Scotland. I've read the local child poverty action reports. There are a huge number of excellent initiatives ongoing the length and breadth of Scotland. In Renfrewshire, for instance, we have claimant support officers in job centres, advice workers within family first centres. In Dundee and in many other areas, there's a lot of work being done to co-locate advice workers within GP practices and other health settings. So there's a huge amount happening, and I just wanted to acknowledge that. The reason for focusing on these two examples today, they're obviously high quality services, they're taking an innovative approach, but they also have a very clear focus on families with children. And that's essential if we're talking about tackling child poverty. And there's also been thorough monitoring and evaluation of the impact of these services, and Karen, and I'm sure Sylvia and Leslie will touch upon that too. And I think above all, I'm hoping that by looking at these services which focus so specifically on children with families with children, there might be lessons that can be drawn for all advice providers and those commissioning advice about the barriers that families with children face, how we help to overcome those barriers, how we capture the impact on families with children, and how we can do more to ensure that advice doesn't just prevent and mitigate crisis, but also helps put families on a firmer financial footing in the longer term. So on that note, I'll hand over to Sylvia from NHS Lothian, who will be talking about Edinburgh's Maximise programme.
Thank you very much. So my name is Sylvia Baker. I'm a public health practitioner for health and social care in Edinburgh, employed by NHS Lothian. My background has been continuing to roll out income maximisation within NHS settings, but Maximise is kind of stepping out of the norm and trying something really innovative and doing something different, using the model that was about embedding welfare in GP practices and thinking, can we embed this somewhere different that actually targets families? And it's thinking about the drivers of poverty, which are income maximisation, employment, so getting money into people's pockets, employment, and also housing, and thinking about it on in an early years setting with young children, for example. And I suppose it's just highlighting that these are the main drivers of public health as well. So Maximise firstly started by putting income maximisation into school and testing it out. We did that for a year in a cluster of schools, and we gained over £375,000 for 91 families in a school year. The reason we didn't stop at that, thinking that was okay, is because the feedback from the families and the feedback from the advisor was that we left people, yes, with money, but actually still, as described, distraught with the effect of poverty and the mental health issues that come with that, the stress. And actually, what else could we do for families? What else could we provide? And actually, generating money is one thing, but actually, if we can help people move along an employability pipeline and actually get into work, we actually could transform their lives. So that's how Maximise was developed. So Maximise is a holistic service, which is a trauma-informed service. So we kind of really work beyond just the service of advice, family support and employability. We kind of really walk into people's lives, and it's quite intense because you hear just not one small part of people's lives, you hear a whole part of someone's lives. And what we do is we provide welfare and debt and benefit advice, income maximisation, housing and tenancy support, employability support, parental engagement. We improve attendance and participation in school. We're practical, social and emotional help for children and families, and building social and community networks. But how do we do that? So Maximise is embedded in schools. So we work in a cluster of schools. Year one was working in one school cluster in Liberton in Edinburgh, where we had one high school and 5 primary schools. And it was using Children First to provide family support, but also in partnership working with CHI, that's Community Help Advice Initiative in Edinburgh, who provide income maximisation and advice along, and they also provide an employability service. So bringing these 3 services together, and in partnership with myself from Edinburgh Health and Social Care Partnership, as well as our City of Edinburgh Council, the 1 in 5 programme, which is about poverty proofing the school day. And together we developed this model of intense family support. And really, In terms of being embedded in the school as one of our partners, we also see this service as not being able to provide everything, but actually we see ourselves as being in the centre of a community where third sector organisations, community assets exist, and we're hooking into all of those services as well. So it's much more holistic, not only for a family support, but it's also holistic for a community in terms of making sure that families are hooked into what is available within their local services, including the statutory services as well. We work closely with social work as well. So this service provides income maximisation, employability and family support. The door of entry is income maximisation generally. It can also be employability, but the most significant one is income maximisation, where referrals come through the school from the teachers, it can come through social work, come through GPs, it can come from the individuals themselves, the families themselves, and it's obviously the parents that we're targeting. The staff from Maximise, they've been described as being seen when they need to be seen, and they're invisible when they need to be invisible. So families come in and they receive income maximisation, and if it's felt that they could do with more support, for example, if mental health issues are there and that there is any issues within the family, that a family support worker could just gently draw alongside and support, then the family support worker will work with them also. And generally in conversation, we would find that a member of the family said, you know, I always hoped and would have loved to be a nurse. And so what we would do in those kind of comments is work with that individual and bring in the employability worker. But for many of our families, it's just about confidence building. It's about assisting individuals to find a structure to their day and look at moving along that employability pipeline, which isn't linear, kind of goes up, down and around about in circles, as many of you will know from employability backgrounds. And it's just trying to support families to be much more holistic in their approach in terms of supporting them. So why does this service work? It's early intervention, so it's reducing risk. So families that have little money, we're getting in there quickly, we're making sure they're getting the money that they are entitled to, that they're getting the clothing grants they are entitled to, their free school meals, whatever it is that they're entitled to, we are making sure that they are getting it as early as possible. It's reducing time and resources for school staff, so it releases their time. There's an increase in the likeliness of parents accessing advice. What we find is that in general advice services, many families, many parents don't believe that they have a right to access money or are aware that they can access benefits that they're entitled to. So it increases their accessibility to advice. It's a comfortable, approachable setting for parents. It's non-stigmatising. Parents may make their first appointment to see the advice worker in the school. They could be making an appointment for anything in a school, because many parents turn up at a school for many reasons. So it's not exposing. And we work in close partnership with other agencies. So we would use our local assets, our youth workers, for example, in the local area, and work very closely with them, our social workers and our health, for example. So in year one, we secured funding through a Health and Equalities grant in NHS and a bit of PEF money from the schools. So buy-in from the schools, I have to say that was really significant. Schools needed to buy into it. And it was a nominal amount of money, it wasn't a lot. And what we did was we set up a long-term holistic model for assisting families out of poverty. So a full-time advice worker, a full-time family support worker and a part-time employability worker. And as I said before, it's 5 primary schools and 1 high school. And the results were that we worked with 90 parents who received welfare advice, had 109 advice issues that were dealt with, 181 appointments on, roughly, most people had 2 appointments. And we gained over $250,000 for those families. That's a lot of money when we consider how much families are struggling. That if we were able to gain that for 90 families, how much more could we do with more families? I think it's been estimated in Edinburgh alone that it was roughly £84 million of unclaimed benefits out there. So we're tapping into a wad of money that could be used to tackle child poverty. So in terms of family support. 20 families were worked with, and families benefit from a range of practical, social and emotional outreach support. 26 parents and carers with 51 children and young people received direct support. 23 other parents and carers and children in the household received indirect support. And 7 families with children with additional support needs were within that group. And 4 children were on the Child Protection Register when we began to engage with them and were removed while we were supporting them. And I think that's quite a significant crossover of showing how much an impact such a service can have. And 3 families had looked after children. The advice length, the average length of family support was 6 to 9 months, and 55% of families supported lived in SIMD decimal 1, which is your most deprived areas. Now I'm just going to put this slide up because many of you will know the Shinari Wellbeing Outcomes, and under these 5 indicators is where we really recorded the impact on the families. You'll have a copy of these slides, and I'm going to leave them for you to have a look at yourselves. Okay, so in terms of employability, the impacts there. The greatest impact is that 3 people have progressed into part-time and full-time work that has been sustained for more than 4 weeks. Now, if you work in employability services and with these kind of families, you'll know how fantastic that is. We're talking about generally a group that are the furthest away from a job, and to be able to assist them into this kind of work. We're also talking about individuals who are in families where it's a rotating door, and from generation to generation to generation that there isn't a movement into work. And intergenerational is part of what I would say this employability holistic service provides, is that we're working with all the generations. We're working with granny and mum who may never have worked, and we're supporting the young person through the school to make sure that actually having a job is important, so that if that young person then moves on to get a job through the support of the school, that actually we're supporting mum to allow that child to stay there. But also we're looking at mum's aspirations as well. And we're tackling some of the ingrained behaviour of where we have granny saying, don't get stations above yourself, I have no work, your mum's no work, what do you think you're doing, thinking that you can go and get a job? You know, our family's always been like this. And some of that exists, and so we're tackling some of those ingrained behaviours. So 31 people have engaged with and received support from the employability worker. 7 parents attended Next Steps, a 6-week employability course. 8 people have progressed, 7 have taken part-time employability and skills training, and 1's entered part-time education. And the others are still working with us. We continue to work with them long term. So the key elements of this are that building relationships with school and staff is significant. They need to understand why we're there and what it is that we're trying to do. They're also the ones that are referring. They can just pick up small little hints that something's not right at home. For example, we had one teacher who said, I just knew this child should have been getting free school meals and I didn't understand why they weren't. And so that was the trigger for them to refer, and they asked, look, would you mind? And we discovered a whole realm of benefits that they weren't claiming, and really moved a family from a real dire situation into a much more stable and much more progressive and comfortable situation for both the children and for the mum. The other key elements are maintaining a presence in the school cluster. So we do feedback. We basically, it's about relationships. We go and we make sure that we're known and that they know that what they're referring is actually having an impact. And so we maintain a presence. We are seen when we need to be seen, and we're hidden in terms of from a stigmatising point of view when we need to be. We provide a holistic, person-centred support to families, so everyone is important with the child in the centre. It's trauma-informed support. Trust and communication with families and the team is important. That is embedded. It encourages schools to invest pupil equity fund in a much more imaginative and creative way, having a greater impact. It links with attainment and the poverty, obviously as discussed, and it's embedded in community assets. And so when the service withdraws slowly and appropriately, the families aren't just abandoned, they're actually already propped and supported by whatever is existing within their community. So going forward, this service has managed through the year one, actually at the halfway report, we managed to secure funding through the Improvement Attainment Care Experienced Children and Young People's Fund to roll it out across the city. So Maximise begins year 2 in the South East cluster, so they're going into their second year, and there's a much greater focus on care experienced children. And the rest of the funding is allowed, as I said, to develop throughout the whole city. And so we have 3 other clusters, one in each locality now in Edinburgh, where we are providing a Maximise service. The Maximise team has expanded immensely, and we've had the privilege of being able to put a team leader in position who can coordinate staff and move the service forward. And families engaged are in co-production to shape and serve the service moving forward. So we listen to what our families are saying and develop the service around feedback that we're getting from them. So they're very much integrated into the service and at the core of it. Thank you.
Okay, thanks. We'll hand over to Leslie Nish now from NHS Greater Glasgow and Clyde.
Thank you very much. So my name's Leslie Nish. I'm a Health Improvement Lead with a role for child poverty across NHS Greater Glasgow and Clyde. And I have had the privilege of being involved in our kind of setting up of our money advice service from its inception. Initially, a carer's needs assessment was carried out in the Children's Hospital back in 2012, and through that we identified, by asking parents really what they wanted when they were visiting the hospital, that their top need was help and support around money worries and financial advice. That was their top priority. As you'll know, a parent with a child, if their child becomes unwell, their life can change in the flick of a switch, and really their lives can be absolutely turned upside down. They might have been working, they might have been in full-time employment, part-time employment, and suddenly they're faced with a life-changing situation where their child is diagnosed with a lifelong or life-limiting illness or condition. It's well known that the negative impacts of poverty begin before birth and accumulate across the life course, and for a lot of our families, they may have been living in poverty previously, and for a lot they may have been working, but it's a massive change for them. So initially the pilot was funded for 1 year to test and see how the service would work, because parents had asked for it. Initially it was in 4 clinical areas, that was in renal, diabetes, neurology and cardiology, and through that year we were able to look at the sort of patterns in terms of referrals and what the needs were for those families. We provided training for staff and increasing their confidence around raising the issue of money. And there was a bit of a cultural shift needed within the hospital to do that. In year 2, the service rolled out, and then in year 3, it moved across all ward areas in the hospital. Evaluation report was commissioned in 2014, and the results of that were really used to progress the service delivery. And now, current service provision, sort of 7 years later, is to all ward areas and all outpatient clinics across the hospital. So what does the service do? The service basically takes a holistic approach to the whole family, so it looks at the whole family, not just the parent and child who are maybe there at the hospital. The service will initially look at entitlements and identify incoming and outgoing budget spends. They'll carry out a better off calculation for families, and they'll assist with applications for benefits, navigating both devolved and non-devolved benefit systems. They'll work closely with clinical nurse specialists and with consultants in the hospital, and they'll gather information and provide appropriate medical information. For example, when there's a DLA application for a child, the service assists with debt and might arrange a payment break or a mortgage break for families to ensure there's no risk of repossession or homelessness. They'll work with other housing providers and they'll negotiate arrears in rent or in council tax. They'll help develop budgeting skills and look at energy and ways in which the family can help to lower their bills. We have an SLA with our commissioned money advice service, and our staff have the same training that our NHS staff have, so they're bound by the same rules and regulations, confidentiality, infection control, and they're very much embedded as part of the service. So if you were to ask the staff in the hospital, they'll say, actually, yeah, our service is here. They're part of the team. They sit alongside our family support and information service, where families can go for emotional support. They can also go there if they require additional support. Perhaps they've been flown into the hospital in the night and literally are standing in the clothes that they're in and they have nothing else with them. So they can get access to emergency funds, which can help support the family while they're there at the hospital. Governance is via our steering group that meets quarterly, and we use our quarterly reports to really inform our work in terms of evaluating and learning, ongoing learning about the service. We very much have always used a partnership approach in terms of we work closely with parents, carers and families. We work closely with all the teams and departments in the hospital, with family support, as I mentioned, with our Children's Hospital charity, with our third sector money advice providers, the money advisors in the hospital, with public health, and we've also got reps from across South Lanarkshire, because recognising that our Children's Hospital serves not only Glasgow but much wider, and sometimes families from across Scotland. So our pathways into the services, I'll show you those pathways in just a wee second, but we have services, pathways rather, for all our services, money advice services across NHS Greater Glasgow and Clyde, and as part of that we carried out training sessions, briefing sessions, and we still carry them out across the hospital. We report in as part of our sort of nursing senior management teams, so that we keep everybody kind of abreast of what's happening in the services. We apply a patient-centred family approach, and we really, it's embedded as part of the hospital, and parents and carers expect to be asked about money. We also have the information on our admission records, so raising the issue with anyone and any family who's admitted into the hospital setting. I'm not going to read through these pathways for you, but just to let you see, this is the financial inclusion referral pathway for our Children's Hospital, and it's really simple and basic, and we use that as the sort of basis to chat through with our staff and the teams, and we have copies on wards and in clinical areas for the staff to use to make it really easy and simple for them, just highlighting who the service is for, why it's important, when to raise money, and how to raise it, how to respond and how to refer. We don't expect the staff to be experts at all around money issues, but we just ask them to be aware that they can refer families in. So our quarterly reports and monitoring and evaluation, it's ongoing, as I mentioned. It allows us to review our referral processes and numbers of families. It allows us to look at reasons for referral and our case studies. It lets us look at who uses the service in terms of protected characteristics. The service has a full EQIA carried out, and we're able to identify protected characteristics as part of that in terms of our data and our monitoring. The outcomes and actions are really important to monitor them, so we're able to look and see where homelessness has been prevented, the number of clients who have received budgeting support, a number who have received advice on energy efficiency and energy awareness or fuel poverty. The service can help with wiping out energy debt and getting heating and lighting switched back on before a family goes home. We're able to look at the number of clients who have basically looked at budgeting and changed perhaps their Sky or their mobile phone package to a cheaper alternative. We look at the number of clients with increased income, number of clients using less expensive forms of credit, and the total amount of financial gains. Also, we're able to track the total amount of debt, so non-housing and housing debt that's managed for families, and we're also able to look at council tax arrears, and it's as part of that as well. We can also track, as I mentioned, the number of BNE families who have used the service. We can track the number of times that we've booked and used interpreters for them. We're able to identify the number of appointments face-to-face, and we can also identify where the appointments, or the referrals rather, have come from, so looking at the clinical areas. And we use that in terms of our project updates and improvement plans around if we need to work with any particular clinical area around increasing referrals to the service. So I thought it would be quite useful just to include a case study. And this case study is a particular family who were referred into the service, and they had a very unwell baby, a very sick baby, and because they'd been spending all of their time at the hospital, they hadn't actually made a claim for child benefit for their child, and they hadn't actually registered the birth of their baby. So the family were supported to register the baby's birth, and then using that holistic approach, they were able to have a conversation and discovered that the client they didn't actually have any help with housing costs, council tax reductions, and on further kind of exploration and discovery, they discovered that the family couldn't actually fill out any of the forms, so it was a real barrier for them. So a child benefit claim was completed, child disability living allowance claim, universal credit and council tax reduction claims were all submitted, and the clients were then awarded housing costs, council tax reduction, child benefit, child disability living allowance and a disability premium, and they were better off by £1,183.88 per month. So it's a really good example of where a family haven't been able to access benefits that they were actually entitled to, and having a very sick child has meant that they really weren't able to do that while they were in the hospital. So we know in terms of our money advice service, we know that it works. A child's illness and a serious illness has a huge impact psychologically on parents, siblings, and even on the child, if they themselves have any insight into that. Parents feel that their life completely changed, and they'll often talk about that kind of before and after order of things. Caring for a seriously ill child is exhausting emotionally and physically, so we know that the service reduces stress, worry and anxiety about money while they're in hospital with a sick child, or even if they're attending hospital with a sick child. Co-location is really important to parents and carers because they said, and they tell us frequently, that they don't need to leave the hospital, they don't need to leave their child, and in some instances the service will actually see the family on the ward area if the parents are really keen not to leave the child's bedside. We know that we're reaching people who might not have used other advice services in the past, and we know that engagement levels are high in our NHS settings, and particularly in our children's hospital. Parents and carers tell us that discussion about money issues following that referral from a clinical nurse specialist feels to them like a natural element of the clinical services and the care that they're provided with, so they do expect to be asked about money. So looking at some of our financial gains for 2018-19, in essence there were a total of 472 referrals made to the service with 301 repeat clients, and total financial gains including debt a total of just over £3.3 million, and an average individual gain per family seen is around £7,000. So the outcomes really speak for themselves in terms of the gains for families. We have, like every service, had challenges, and important to recognise that family circumstances can change at any time. So some families might find that there's some massive impact in their life, and then there's another change again. They can have admission and be readmitted again, and that can impact on their ability to earn and look for work. A big change in the hospital was actually changing that culture around staff raising the issue of money worries, and having that conversation. So we continually do promote the service across. Another massive issue for us is funding. The service is funded by Glasgow Children's Hospital Charity, and we know that we need to apply for that funding on an annual basis. And the other issue that we have is the service is getting busier. We know we've got increasing demand for our service. The average number of cases per family can be anything about, average is about 6, and we've got increasing complexity there. For families are facing a whole number of issues there, and again the full impact of universal credit is not fully known as we await the rollout of that. So NHS settings we know have it is that unique opportunity for intervention at key points within the family journey. We know we've got direct access to clinical information and special advice, so the service can use that in terms of completing applications on behalf of the family. Co-location is really important, most effective, and we know that our NHS settings secure high engagement rates. It's destigmatising and acceptable to families, and the reach of service extends to those who are probably most vulnerable in terms of the clinical pathways. And we also use the data from our service to report on our local child poverty action plan, so in terms of our actions to mitigate. There's a couple of film clips that are in. I'm not going to have time to play them, but they're there for you, and I think the presentation will be circulated, so you can have a look at those. It just shows a cardiac nurse from the Children's Hospital and the service from her perspective and what she does with families, and then a family talking about their experience of the service. So in summary, parents and carers tell us they routinely expect to be asked about money, and that's a direct quote from a parent from the Children's Hospital. They have a high level of trust in our NHS staff, and this definitely impacts on the engagement with the service. The engagement rates in our service tend to fluctuate, but generally they're around 94%, and we know that there's real need to continue to support our service, and money advice in our hospital setting really does work. Thank you.
That's great. Thanks very much, Leslie. Just pass over to Karen Carrick there.
Hi, thanks very much. I'm the evaluation manager, so we look at various types of evaluation that are the best way to measure the activity that's ongoing. In terms of the two projects here, which are fantastic examples of delivering advice services in a setting that's close to people and meets their needs, we're looking at a social return on investment or social value approach. The reason that we do that is it enables us to value the outcomes or the changes that are experienced from the perspective of the person or the organisation or the agency that actually it has the outcome, experiences the outcome. It also allows us to consider the impact by looking at a whole host of things that will contribute to the change that's actually measured, and that could be, for instance, what would have happened anyway, what other contributory factors are there. As part of the process, what we try to do is put a financial value on things that you wouldn't normally place a financial value. And we do this because it helps to illustrate the impact of an investment in a particular project. And whether we like it or not, in these current times of financial restraint, that kind of evidence is really essential, and it can be quite compelling for decision makers in terms of how they allocate funding. And whilst both these projects are brilliant examples of what's happening on the ground, as you will have heard, their funding's not secured and it's not on a long-term time basis, and we really need to think about how best we can assist them to achieve that. We are looking at the Maximise project and are applying a social return on investment approach to that now. You'll be relieved to know that I'm not going to go into detail about what social return on investment means, beyond saying that it's principled and is based on, as I've said, the stakeholders. So in the Maximise project, we've identified 5 key stakeholders that we're looking at in a bit more detail, and they are obviously the children and young people who are benefiting, and as Sylvia has said, they are experiencing some of the Shinari outcomes, which will also in the longer term lead to them having improved attainment in schools. We're also looking at the schools, and there are benefits for schools through the kind of programme that's been delivered in terms of establishing better relationships with parents. And parents have often reported that their own experience of schools when they were children is not always positive. So anything that can be done to improve that and increase the impact of parental engagement in children's education, which we know has long-term benefits in terms of attainment, is to be welcomed. Again, we're looking at the families, the impact on families in terms of financial security and stability. But there are also benefits for the public sector. In Scotland, we spend about 10.7 billion on mental health and issues related to it. And we know too that people who live in areas of deprivation, which are the people that are targeted by this project, are 2.5 times more likely to be on antidepressants than people who live a more affluent lifestyle. Also, the actual project, the projects who are delivering Maximise, there are benefits for them too. And I was at a meeting recently where they talked about the F word, and that was in relation to funding. And they have very much a collaborative and cooperative approach to funding, and they look at how they can maximise the use of the funding that they have and how they can deliver improved and better services to the people that they're servicing. I know that what everybody likes about social return on investment is you get this ratio that tells you for every pound invested, you get X amount of social and economic benefits. But I would caution that and say, whilst it's very useful, what is probably more useful is looking at the kind of longer term impacts on people through the process by looking at the outcomes that activities experience. For instance, the Maximise project and the Sick Kids project will have benefits for local communities in that people will have the resources and energies to take part in community activities. It will also likely increase spending in local areas. Children are more likely to have a better start to life and be more likely to fulfil their potential, which benefits us all in the longer term as a society and community. And ultimately, this will result in cost savings for the public sector. So in conclusion, what I would really like to say is that the Improvement Service very much welcomes the opportunity to work with these projects and to enable them to demonstrate and evidence the excellent work that they are doing.
Thank you, Karen. Just to remind our audience that we now have an opportunity to ask questions for all the panellists. For those of you who joined after we began, if you look to the right-hand side of your screen, there's a small box with questions. If you just please type in your question there, and if you want to ask a specific panellist, please type in their name as well, and I'll direct it to them. We've already got a few coming in, and our first question is for Sylvia. The question is, how are you measuring improved attendance with school children?
That's a hard one. I suppose it's from feedback from the schools mainly, and feedback from the parents as well, in terms of their feedback they're giving us, but more so through the schools. In attendance, is that right, or was it attainment? Sorry.
It's attendance.
Attendance, yeah. So it's feedback from them, particularly with families we're working with who have poor attendance because they may have been referred through that avenue. So it's more the feedback that we're getting as a collective, as a group, because we would be working closely with the school in terms of that.
Okay. The second question is also directed to you, Sylvia. There's a staff member looking how you got buy-in from schools to use their PEF money in that way. Their own experience was it's frustrating, and they were looking at advice how to do it. Yes,
I think that's a national frustration. I think PEF's been around now for a few years, and I think in terms of schools, it's very difficult when you're working with schools who have worked in a certain way and they're used to spending money in a certain way, and they had cuts in certain departments and certain areas of their work for them to replace that. And I think in the last 3 years that's probably now happened, and my experience with the schools that we've worked with is that they're now looking for something different, because what they've always done and they've always felt kind of helped, they've kind of tried that and it's not making the impact that they really would as much like it to make, and need to make a greater impact. So I think there's an openness to hear different ideas. And to be honest, it's a bit of banging a drum, and I'm very good at banging drums, and it's a bit about getting yourself there and starting to speak and give some evidence and about some examples of different ways of spending PEF. It's about forming a relationship with schools and for them to trust you. So relationships, trust are very essential to that, and encouraging schools to hear different ways of spending PEF. It's very easy to buy everybody an iPad, but it's not so easy to give everybody the internet at home to be able to use that iPad. So it's trying to find different creative ways of being able to make it a universal approach rather than just for those who are able. So it's trying to encourage schools to really think outside the box. And I think there's an openness for more of that now than there has been, but sometimes it is a bit about kind of just keep tapping away. Because I think schools also, my experience is some of them aren't as open as others, and they kind of have a closed way of working. But if we keep that way, nothing's really going to change. So we really need to go in and start talking about partnership working, talking about families and not just children, talking about communities, and using, I suppose, the integrated model and health and social care as an example of how integrating communities together and working together is how we are able to make a difference.
Thank you.
Yep, thank you. So another question directed at yourself, Sylvia. What level of poverty awareness did school staff receive?
Okay, yes, I would say that we were very fortunate that we kind of had somebody snowplough that for us. So we have a 1 in 5 programme in Edinburgh run by the City Edinburgh Council, CLD workers, and they had done a lot of training on poverty proof in schools. And that was a bit about what does poverty look like, helping staff to understand what poverty looks like, to assist them to recognise some of the telltale signs they might see in kids or families, or just to have a hunch and go with it. Also, we used exercises where we would use situations, give them out money and a scenario and say, right, we want you to try and spend this money and not get into debt, and to budget. And that budgeting experience actually really revealed to many staff actually how difficult it is for families to manage on a very low income, and exposed how significant and important it is for even just, for example, saying bring £1 to school and wear your own clothes. These kind of opportunities actually can be what breaks the back of families, and so we need to be mindful of that. These small amount of money are actually make a difference. So we were fortunate, yes, they had quite a bit of training beforehand and snowploughed it for us. So I'd certainly advise that that's really where to start.
Thank you.
Right, to take the pressure off Sylvia for a bit, I've got a question for Leslie. What would you say was the biggest challenge you faced in setting up the programme, and how did you overcome it? If you could give some advice to people who might be thinking about doing something similar.
In terms of setting up, I think some of the challenges were even around where could we accommodate a service in the hospital, because our hospital settings are crammed full. Clinical areas, rooms, everywhere is just full to bursting. So that was a challenge. I don't think it was a challenge in terms of changing hearts and minds around the service, because I think the staff, they were identifying that they were already beginning to have conversations around money worries, and certainly our family support team there were also identifying that. So I think there was some challenges in terms of they were identifying the issues, but they didn't have a service specifically that could help address some of the issues that families were facing. And I suppose really in terms of we worked closely with all the departments in the hospital, facilities and everybody to make sure that we could get the service in there. It was never really a challenge in terms of getting the referrals in, but we did have to change some hearts and minds around actually what is poverty and what does that mean for families, and what, how we could support families there in the hospital. So we did have that as a challenge.
Thank you.
I've got a question as well. It was something that Leslie, you mentioned, but I think it applies to both speakers. You had said that you had the impression that a lot of the families that were accessing advice through the hospital hadn't accessed money advice in the past. Is there any sort of learning from your projects about how we can remove some of the barriers for families to information and advice in the community, that might not otherwise come into contact with your service?
That's a tricky one. I mean, there will be families who have children who are sick and maybe they're not admitted into hospital. Yeah. So where, how would they access local services? I guess it's that bit of making the services as accessible as possible. So it might not be your conventional high street. It might be within a school setting. It might be within a hospital or a GP practice. And I guess it's about using the knowledge that families have and using that to help direct where services would best sit in community or in a hospital or whatever setting, really.
Yeah.
I would certainly endorse that. I think we need to go where families are, and so often we work in a way where we expect families to come to us, And I think that those days have gone. I think we really need to embed ourselves into services where families are. And certainly we are certainly looking at expanding into early years centres as an example. The earlier you intervene, the better. But there's others, community settings. We certainly have advice in community settings. So it would be about where services are. I think there's also a bit about training up staff to be aware, and I think you touched on that, Leslie, that actually from a health perspective particularly, the social determinants of health and income is a massive part of that, that we really need to be making sure that staff are owning that as part of a health issue. Because unless we really sort out people's money, it's fundamental, it's Maslow's hierarchy of need. If it's not sorted, there's no point in starting to teach somebody how to take their insulin injection, because actually they don't know where they're going to get the money to be able to eat the food that they need the insulin for. So it's about breaking that down and making sure that staff within NHS and all settings take that on board as part of their role. Schools is part of their role as well. In this day and age, particularly with growing child poverty rates, it's everybody's right. And I think that's part, it's everybody's right to keep a child safe. And this is part of that safety as well, part of that situation.
Okay, thanks.
Yep, I've got another question for Sylvia here. They're interested in the outcome to child protection. For instance, how children were being removed. How have you worked with social work teams involved with families concerned?
Great, we've got a fantastic relationship with social work, and they've very much welcomed our involvement. They very much see the holistic side of the service. They certainly provide us with referrals, and we certainly have involvement with families who have social work involvement. I think it's about that mutual respect about who's got roles and what roles we all play, and it's respecting that, but it's also working in a professional way. Our team leader is an actual senior social worker background, so is very familiar with those settings and how corporately or statutory services work, so knows how to interact with those services. And I think in terms of when you're able to produce outcomes as we have, that makes people stand up. And it's outcomes that are the thing that speak, and it's families that are the ones that it's impacting and having a difference. So I think the difference that you're making to these families is what then speaks loudly, and as that spreads and that information gets out there, then more and more are involving. And social work are actually overwhelmed, so if somebody else to come in and help and support is very much welcomed as well.
So in relation to outcomes for the schools, who did you get partners to feedback outcomes and financial gains to? In terms of how did we feedback that information, or how did we find out those financial gains?
How? Who did you feedback the information to? I think
right, okay. So in terms of our outcomes, I think I would say in my language, the world, we feed it back to everybody. So all those who are involved in the service feed it back to, we feed back, so all our evaluation, all our information that we gain, we feed back, we tell families the impact it's having as well in a very watered down version that makes sense to them. We feed back to the schools. It's really important if we want to continue engagement, they need to know the impact the service is happening, because they don't always see it. So it's good for them to know that what they're referring in is working. We feed it back strategically, that's really important, more so from a strategic point of view, that people know and that they are taking that on board, particularly from a funding perspective, and also we're feeding it back nationally as well, to services like yourselves once they're listening. So many avenues does that information go out, and yes, income generated is probably the nice kind of one that people like to hear, because it's the one that kind of has a big impact.
I've got a question for Leslie. You talked about training programmes. So what did you actually do to win hearts and minds of the sceptics?
So initially in the pilot phase, we developed the training very much with the nursing staff and medical staff in the hospital around what the needs of the staff were. As I mentioned earlier, families were at that point raising money as an issue, so we knew it was an issue for families. So we explored some of the issues, what the staff were seeing and what they were identifying, and we developed a kind of package, and we would attend clinical nurse sessions, the clinical nurse specialist meetings. We would go to the senior management teams to very much embed it right through the whole sort of hospital system, working with the staff to make sure that it met their needs in terms of improving their understanding. And actually, it's always been about sort of challenging that medical model. And as Sylvia mentioned earlier on, getting people to see the value of recognising that money is plays a massive part in terms of all our health, and that flick of a switch could happen to any one of us at any point in time, whether that's through becoming unwell, whether through losing your job, a separation or a marriage breakdown. And so staff would then see that actually, that this is an issue for all of us, not just for our families who are visiting the hospital. It was very much an approach that we built on it as we went along. So we used the learning and the monitoring as we moved along to improve the training and the services that we provided to our staff.
Would those training programmes be available for others if they were interested in adopting this?
Absolutely, we're more than happy to share. We're in the process of sharing with Sylvia and her team at the minute. And yeah, we also have our sort of e-module. We've linked into NHS Health Scotland's e-module, and just really just kind of sharing. Absolutely, I'm more than happy to share that. Thank you.
Just another question from me for Leslie primarily, but feel free to chip in, Sylvia. Under the child poverty legislation and guidance, local authorities and health boards are asked particularly to think about priority groups. So these are the groups that are at highest risk of experiencing child poverty. So ethnic minority households, households in which someone is disabled, but other groups including lone parent families, families with 3 or more children, families in which the mum is young, so under 25, and families in which there's a baby under the age of 1. Can you draw out information from what you gather already about the proportion of households in those situations that are accessing your service, so we can understand if we're reaching the most vulnerable to poverty groups?
Absolutely. So through our quarterly reporting system and through our SLA, the structures that are set up there allow us to extract that information. So we're able to see exactly the groups that you've just mentioned, Hannah, and we're able to see where we're reaching those families, what the outcomes are for those families, and importantly, the financial gains for these families too. So it's really important that we have that as part of our monitoring process. And as I mentioned, through our EQIA, we're monitoring the protected characteristics, so that also helps in terms of being able to achieve and demonstrate the outcomes.
That's great.
Yeah, we do the same. One of the most obvious one was that from an ethnic minority, we know that they're a group that don't access advice service readily, and particularly the female in the family. And in terms of having it embedded in the school, we do know that parents, the females are the ones that are taking the kids to school, and actually we have had a considerable amount of ethnic minority individuals accessing the service because it's accessible to them and a place that's safe for them. Particularly the trust transfer of the school trust to is transferred over to us, and we've certainly seen an impact with these families, and very much the others described. A school has all kids have to be registered to go to school, so therefore we have access to all families. So therefore the mix is as great and as wide as it can be. So we're able to monitor that as well.
Okay, thank you.
Okay, we are now coming to the end of our time at the webinar. I'd like to thank our presenters for giving us their time today, and for all the delegates who sent questions in. Just to let you know, this webinar is recorded and will be sent out in due course, along with the slides, which contain some videos which we recommend watching as well. I'll just pass over to our presenters for any final comments they may have, for instance, places to contact or information sources that they should be accessing.
Okay, I suppose just to say, the webinar will also be posted on the Knowledge Hub for local child poverty action reports. Karen, I don't know if it will also be on any other Knowledge Hub groups.
We'll certainly share it with the ones that we advertised it through, and we'll also put the results of the evaluation we're doing on the evaluation page of the website too.
Okay, that's great. So that'll all be there. I've had some emails while the webinar has been ongoing from people who were trying to register but couldn't. So I would just ask, if you hear from any of your colleagues that they weren't able to get through, if you ask them to get in contact with myself or anyone else that's been involved in the webinar, and we'll just make sure that they're on any mailing lists and that they have access to the webinar.
Okay, well, thank you everyone again. I am just going to say goodbye from us, and we hope you'll tune into the next webinar. Thank you.